sexuality. But many of them do not actually assess experience of care. They only assess the quality, but what women experience, they don't. And also some of them actually need to be consolidated, validated, and expanded depending on the program or whatever is being used for. And actually there are limited studies that are assessing programs and policies in respect of the user experience with health facilities. So from there, we move to the next subgroup or secondary analysis. Here was this was a very important paper, which is also very dear to me, especially when examining women and we are mistreating them as well. So our idea was to explore 4 types of mistreatment during vaginal examination. One of them is non-consented care, which we said it was about 59%, and also how sometimes we just expose their genitalia. Just before this presentation, I was told that it's actually women actually go through a lot when a doctor or nurse say, "Oh, let me examine you." You see, it's not easy to just expose yourself for somebody to examine you. I can see it's not easy, and so just when you don't even tell them, and you just, because they can't speak, they don't have the power to talk, so you just enter their privacy like that. It can be very dehumanizing, yes. And so it's something that we should be trying to reduce. So we found out that absence of, you can see, we have already mentioned, so women, another thing women complained about was the fact that we share their information without telling them. You see, you have examined a woman, you know what her findings are, and then you just talk to people about what they find without telling them or asking them whether you have the right to share it with other people. They are in labor and you meet other people around and you are telling them, oh, it may be a doctor, your senior doctor, but you need to take permission because you are the one they know. You need to take permission from them and say that your findings I want to share with mine, because they don't know if this person is a professor. They will not know. All they know is that you are my doctor, my nurse, and you are telling what I've told you secretly to other people, and they feel very uncomfortable. So we found out that sometimes in doing our examination, we just expose them anyhow. We don't cover them. We expose their breast in addition, and that occurred in about, breast exposure was about 25%. Genitalia exposed was about 28%. And most of the time we realized that absence of privacy measures such as curtains were actually associated with sharing of information and genital exposure and so forth. And so this is something that we should be considering. If you look at this graph, you can see that in Ghana, actually, non-consented vaginal examination, it was very high. And you can see that in Guinea and Nigeria and so forth. But I think we did well with genital. We are a little more careful. We don't expose so much. In terms of information, we are careful. We don't share so much. But if you look at the other countries, you can see they can just expose the breast in the process of examination, vaginal exposure and so forth. So what can we do? What is the implication of these findings that we have found in terms of mistreatment of women during vaginal examination? We say that our results highlight the need to ensure better communication and consent processes for vaginal examination, especially during childbirth. In some settings, measures such as the presence of curtains actually will improve the prevalence or the burden of this. And we need to consider context-specific interventions to achieve this, especially in our part of the world. This other analysis also talked about adolescent experience, where we decided to look at adolescents, what they go through. And in this study, you can see that we compared the adolescent with the young adult, that is 20 to 24 years, compared to the 15 to 19 years. And you can see that 15 to 19 years constituted about 33%, and the rest were young adults. And most of them also experienced a lot of verbal abuse and physical abuse. And poor communication, you can see, this was even higher compared to 36% in the adolescent compared to 31%. Poor communication, 32% compared to 29, sorry. Lack of supportive care, 42% compared to 33. This was really wide. We left them a lot. And then lack of privacy, that was also the difference. And we realized that verbal abuse, women were more likely to be, women who were verbally abused were about 81% likely to report being satisfied. If they were not abused, then they are likely to report satisfaction. But if they are abused, then they are not happy about that. And then we can see physical abuse, also the long waiting and lack of mobilization I mentioned, and non-consented care was also a factor. Then when we finished it, we realized that no, what about the neonates? Because studies show that if mothers are mistreated, it's likely that their babies might be mistreated. And so we decided to look at the first 2 hours of birth, how babies are treated. We wanted to find out the prevalence and factors associated with neonatal care practices. And we realized that separation of mother and baby was so high, more than 50%. Actually, WHO recommends that immediately after delivery, there should be bonding. And in more than half of this, there were separation. Separation was associated with being single. Women, I don't know, but women who were single had more, they were like 1.8 times more likely to have that separation. And then lack of maternal education was also associated with the likelihood of newborn not actually getting the recommended, WHO recommended practices. For example, no immediate skin-to-skin care, maternal and newborn separation, and also no breastfeeding on demand. These were things that we found within the first 2 hours of delivery among women who were mistreated as well. And low birth weight women were low birth weight newborns were more likely, of course, to be not to initiate breastfeeding because maybe they were sent to NICU or other factors. And then when women actually experience physical abuse within 1 hour of childbirth, their newborns were more likely to be slapped. Slap in the sense of, sometimes they tap that's what we mean by slap, like tapping the thigh in terms of maybe resuscitation or some other forms of it. But the WHO doesn't recommend that. In terms of resuscitation, you need to slap the baby. So the observers, like the RAs who were trained, picked some of this. And there was high proportion of newborns who actually did not receive the recommended care practices. And in fact, some of them, including the most vulnerable, actually receiving practices that are indicative of poor quality of care. So these were some of the things that also happened to the neonates of these women. So in terms of tool, we use a community survey where we interview them 6 to 8 weeks to develop a tool to measure mistreatment of women. And you can see that this is Ghana, Guinea, Nigeria, and so forth. And you can see there was good sensitivity for this tool. You can access this paper and read about the details of the tools, a specific like component of the things that we put in the tool that is used to measure mistreatment of women based on community survey, because we realize that we cannot always go and observe women in labor, even though the studies show that we had a lot of this. But if the women went home and still remembered that they were mistreated, that can have a very long-term emotional or psychological effect on them. So looking at how the labor observation tool, where we observe them, looking at all the factors, we use that also to develop a tool. So those who want to look at labor observation tool alone, they can also look at it. So in this case, we had about 7 items which described interpersonal abuse scale. And then we have 3 items which looked at examination and procedures that we did. And then other 12 items. So you can see 12 plus 3, 15 plus 7, that's 22. So this constituted the labor observation tool, each of them having its own component. And this was the scale had a reliability coefficient of 0.71 in Nigeria and approach relatively lower in Ghana, about 60% or 0.6%. And these were the factors. So if you want to look at the further, the factors included were the 7-1 included shouting, insulting, scolding, mocking, and so forth. And then vaginal examination, no information or no consent, exposure, and lack of confidentiality, and so forth. So these were components that we put in the labor observation tool. So if you want to measure after all this, you can have, if you get all of them, it can be put in a situation where you can see and measure the level of mistreatment that women go through. So what is the implication of all this? These have generated a set of concise, comprehensive, multidimensional measures of mistreatment that can be used in future research and also can be used clinically to assess. What I think we should be doing is that when this study was done in Guinea, for instance, the Ministry of Health have incorporated some of these things in Guinea after the study, and they have started asking questions so that when women after treatment, there are questions that you can ask them to find out if they were mistreated or not. And this can help with quality improvement measures, and in the long run can improve care. And so how do we put all this into practice? WHO, after some of these studies, have converted or produced guidelines or recommendations for treatment to be used in most countries. And you can talk of the antenatal care guideline, which will generate a positive pregnancy experience. Then intrapartum care, also generating positive childbirth experience. And more recently, that was about in March or so, more recently, the WHO published the postnatal care experience. And that is the current one that has been published. But apart from that, there are other things that we can consider. So having talked a very long time on all this, there's another concept that I think we should be considering. And I think you agree with me that the concept of caring for the carers. You see, we have talked about women being mistreated and all that. What about the carers, the midwives, the doctors, the lower level, not the higher level, the lower level staff? Most of them, they have been studied to show that actually women, especially if you look at in our part of the world, the West African or Sub-Saharan Africa, as much as 53% of these health workers, midwives, are mistreated. They are disrespected by their colleagues, by their superiors, and sometimes even by the patient. And when they are disrespected, they also, and studies showed from what we presented, they get frustrated, they get worried and angry, and they can now channel their anger onto the poor patients. And I think even though it's not right that you get angry and you dissipate your anger on the patient, they are also human beings, and sometimes they are not able to control. So there's a need for us to look at the carers themselves. For instance, most of them do not have, they are treated badly by, sometimes doctors may treat midwife badly, senior nurses may treat young midwife badly, senior doctors may treat young doctors badly, and so forth. And so they get already, as they come to see you, they are not happy, they are stressed, and they may not be able to kind of get the rapport you want, the woman will want to have with the patient, with the doctor. And so these are things that I think we should be considering. So there's a significant social, cultural, and economic, sometimes we are not paid well, and you think about what to eat and all that, and they come and they dissipate their worry on the poor patient. And I think we should be able to, we have psychologists who can talk. I think there should be regular psychology intervention for health workers as well. We go through a lot, and most are depressed and have challenges, and that will also help us. So based on all this, WHO made some recommendations that there should be greater support from government and development partners for research and action to disrespect and abuse. And there should be greater support to initiate and sustain programs designed to improve the quality of care. And there should be an emphasis on the right of women, especially in terms of dignity, respectful care, throughout pregnancy, childbirth, and postnatal period. And there's a need to generate data to back all these things, and all stakeholders are to be included. So I'll try to bring my talk to an end by saying that mistreatment of women is pervasive in West Africa and in Ghana as well. As I mentioned, other studies have mentioned it in Ghana even before our studies, and we need to accept that and find ways and means to go around that. Younger women, less educated, they are at the highest risk. So we should make a conscious attempt. Let me say that one day I took care of a younger patient, and the outcome, she was, I think 15, she got pregnant, and I think she didn't get a baby. She was so worried because she told me that she doesn't know what she's going to say, because when she got pregnant, what she had gone through in the community and now losing the child is worse. She doesn't know where to go, how to go and say what to say. And I felt very badly, I mean, with what she told me, and it has always been on my mind. And one time, when what we have not mentioned was that sometimes the doctors also go through a lot of stress. Sometimes the patient doesn't have money to do lab, they don't have anything, no support, and you try to navigate through how to manage them. And so we need to be addressing inequalities, so that we can promote respective maternity care for all women. And there should be programs and policies that can help us to achieve this and produce positive pregnancy, childbirth, and postnatal experience for all women. And this action is urgently needed to actually go through all that. So this is the end. These are some of my references that we used for this presentation. You can see these are our partners from other countries and WHO partners. And this was 2015 where we were starting the program. This was done in Noguchi here, and you can see other members. We had like a short seminar in Noguchi. You can see Dr. Maya here also, and our friends. And I want to make a special mention to UGMC for giving opportunity to present our work here. I am very grateful for that opportunity. I must say I'm also very grateful to Professor Adano for involving me with this. I would say he has really helped me a lot, because when I was young, finishing membership, then she called me one day, Kwame, this lady was in Ghana, this we call Oski, and can you help Oski do this work? And I also had a thing that a friend told me when I was young, that a thing doing is worth doing well. Whatever your hand finds doing, just do it like it's yours. So I did it well with whatever they asked me to do, I did, and that was the beginning. And so, Prof. Adano, I'm very grateful. Dr. Maya was part of the study. Oski, Megan, they were all WHO now. Megan is in Australia, and Joshua, and SPH, UGMS, where I teach, and my department, and also my family, where I do all this kind of research and art, manage clinic as well, and all that. And family is very supportive, allowing me to run away from most of the work. Thank you.
Thank you very much, my personal person. Please, question time.
Thank you very much, Kwame. That was excellent. I really enjoyed. I have a question and a comment. So my question, part of your findings show that some interventions, especially CS and things, were done without consent. Do you have any information on whether the partners of these women were consulted, maybe because the women were in such a state or something? Did that come up? And then I'm also very happy you talked about, taking care of health workers, because the phenomenon that you describe, people, midwives being disrespected, nurses, doctors, all that kind of thing. There's a phenomenon called displacement in psychology. So you do something to me, you are my senior, I can't respond, I take it on my, and sometimes even as parents, I mean, in my own life, I've seen that sometimes I'm shouting at my children and the shouting is over and above what they did. But the mistress about, and I'm just, because you can just displace to that. So it is good that we look at that. Self-care is important. Well-being now is actually an ethical responsibility for us. You know that the new Hippocratic Oath tells us about taking care of us. Even though we don't do physical well-being a lot, we hardly do the mental and psychological well-being. So I'm glad that your studies highlighted this, and Dr. Wama is here, so UGMC is going to be great at helping us take care of ourselves. Thank you.
Right. Thank you for the question. This is very interesting. What we did, it was direct observation. You watch them in labor at a point in time, they needed cesarean section. Maybe I thought doctors, the idea, some people think that these people are in quote illiterate, they don't understand. So we do cesarean section. A time has come for cesarean, and they do. As I said, the percentage was higher in the observation, but when it came to the community, it has gone down a little. Maybe we don't know why, but maybe they have forgotten, or they think whatever was done for them was okay, and therefore they are okay. And some women will always tell you, doctor, you are the doctor, do what you feel is good for me. And so I think we hide behind that. So it was direct observation, and that's what they saw, that when the time was due for the cesarean, they were not consulted, and they were just kind of prepared for cesarean section. Doctor review and say, oh, failure to progress for cesarean section. Then patient is not told, patient is not, and before you realize, madam, then or sign here. They don't understand what they are doing. That kind of thing. Thank you.
That is why UGMC, you need to use AIDET. When you use AIDET, you get your patient involved in the care of their selves, isn't it? Isn't it? So let's continue using AIDET so that our patient will not say that they were not told, they were not part of their care. Okay, there's a question here which is asking, what are the comparable rates of such mistreatment in the Western world? And did you consider the contribution or the effect of medical and nursing training to this as a problem?
Yes, so as I mentioned, even though mistreatment of women is global, originally we thought that it's more limited to the developing world or the low and middle income country. But there are studies like, as I mentioned, Clerk et al. In the Netherlands. Netherlands have one of the lowest maternal mortality ratio, about 5, sometimes could go to 4 or less than 10. And they even mentioned that the women actually complained they were treated badly. The doctors and nurses were insensitive. Vaginal examination were painful. They were used like an object, and so forth. And another study that was done from the same place showed that even most people who die from hypertension were due to substandard care, which include a lot of them. So in terms of that, you can see it's not only limited to our country, and in the foreign world, it's also occurring there. So I still think that probably is higher here. I mean, in our developing world where we don't have, but you know, in the developed world, I think they have a way. If you don't talk to a patient well, you can be sacked from the hospital. Our policy, I don't think we have got there yet. And so I don't have a study to show that, but I can imagine it might be higher, because when somebody does something in the hospital and you need to sack the person, we can rather change them from one point to another. When the person was on the first floor, we move it to the second floor, and that's what we do. And I think that doesn't, but out there, friends out there, when you see a patient, you have to kind of stimulate. You have to smile. Oh, madam, this just so that, let the patient know you have got that moment. Yes, but we are not able to play that act. I think we should learn to play that act.
Okay, at UGMC, we are playing it quite well. Great. So Kudos to the team and Dr. Bonsafo for the insightful work and presentation. What strategies, in your view, can be utilized to reduce or eliminate such mistreatments?
So, yes.
And
okay, let me
then
answer.
the other one, the last one from online, which I have here is, what cadre of health workers were more likely to mistreat clients?
Good. So let me mention that when we did a vagina examination, we led the vagina examination paper. So we kind of wrote it with support from them. So the recommendations we made were that one, this mistreatment issues and the questions and all that, even though I think we teach in medical school and nursing school and midwifery school, it has to be we have to be active on it. And the Ministry of Health will also have to come in. Maybe we think that those who have been trained already, doctors and nurses, they need rehearsals to be able to regular rehearsals to be able to remind them of it. Otherwise, this can come in one form or the other. And so these are some of the things that we mentioned. The other thing I want to comment to answer is that if you look at the people who we actually asked, midwives and doctors and administrators, and we realized that we haven't done a specific analysis to know which of the midwives were doing that, but mostly midwives were the people we observed in labor, and then almost all of them are midwives. And Ghana, we do not have male midwives actively. If you check, it's now that it looks like we are trying to train some, but in other countries, it stopped, right? Okay, I check online when we're writing the paper because in Tanzania and other places, they have male midwives. When I check, I think there was a school, but as director is saying, okay, they did about 2 years and stopped. Thank you. So these are some of the things that we need. So we don't know exactly. That's why we don't know which people are causing this. Is it only the doctors, and even the doctors, which one of them? Or the midwives, are they the lower ones, are the stressed ones, or the senior ones? Or it's difficult. It's a complex thing that we need to start. And I think maybe as a country, we should look at ways and means to go about it.
Thank you, Dr. Adubun-Safo. I think before I go on to my comments and possibly questions, when it comes to ethics, we are taught, but you see, we tend to learn from clinical practice, okay? We tend to learn from our seniors more than what we are taught. So what they do is what those behind us who do, okay? And as we said, I mean, those in the system already need to be retrained so that we do better on the clinical grounds. But I think your conclusion answered most of my questions. So for me, I think this mistreatment, especially in this part of the world, I can attribute it, yes, human factor is there, but our health structures and then also the financial aspect, education, and then the lack of resources and training, okay? Because if the person gets to a second stage, the head is there. I've forgotten my terms, what you use to pull them. If it is not there. Yeah, the vacuum.
Yeah.
If it is not there for the midwife or the doctor to use, what do you think will happen? They will slap for the mother to for the mother to put.
Yeah.
Because I mean, during my training as a medical student and also housemanship, I realized that when they do that, the women push.
They beat them. They slap them.
When they do episiotomy without anesthesia, the baby comes. They push. So I was wondering, so these things, should they do it with anesthesia or without anesthesia? But I think your study have shown that it's a form of mistreatment.
It's a mistreatment.
So we shouldn't do that.
Yeah.
Then I think other thing too is the process, as the moderator is saying. when the women come to labor, probably we don't sit them down initially and tell them the stages you are going to go through. When you go to the second, you ask you to push. If you don't push, this and this and this will happen. We don't tell them. So they just come when they get, hey, push, push, push. So I think the processes also should be explained to them. I mean, when they come initially during labor. But you said genital exposure. And I was wondering, how can a woman come and deliver without exposure?
Okay.
There should be exposure. So that one, maybe is it improper exposure or is it?
Okay, let me mention
my last one.
Okay.
Then you said the single women were more likely to suffer like separation from.
Yeah.
Is it the women that came without
We're not
their
married.
partners? They were not married.
Yeah.
They don't have partners.
They don't have partners.
But they are pregnant. Okay, thank you.
Okay, Dr. Ria, thank you very much for your comment. These are very, very important comments you have raised. I'm happy, even though you're a physician, but you have made this very good observation. One of them, in fact, we wrote in the paper, we recommended that women during the time of pregnancy, we should tell them what they should expect in labor, because sometimes it looks like we don't tell them their expectations. So they come, some of them can even ask of, they think the water, sometimes when the National Health started, they thought that when you come, even drinks and everything is supposed to be provided by the National Health Scheme. And so we need to tell them. And then the exposure, the vaginal exposure, the perineum, even as Dr. Boama is here, if you want to examine somebody, you know you are going to examine the private area. We were taught that you still have to cover her area, even though you are now going to examine, you don't just open her up, cover her, and you can examine her from down. You get the idea. You have covered her. It's a form of respect that it's not your fault that you are going to invade her privacy. If you had a chance, you wouldn't, but you have to. So we do that, but some of them, they just remove the thing and it's not good. You can't just touch a woman, remove her, and then you are examining her. It's not good. But let her, madam, please, I want to examine you. Can you expose yourself a little for me? And ask her in a very nice voice. At this point, it will involve a little discomfort, but I'll try to be a little careful. And I have your chaperone or somebody here to guide you and all that. So we will be very careful. If you have any pain or discomfort, please, you can let me know so I can, that kind of thing. When you tell a woman all this, they are okay. By just removing her and sometimes nothing is covering them, then you are examining them, it's not good.
All right. Thank you very much. So this is an area that I've worked very closely with. Yeah. And I share a few things. One is being naked in labor was like some common practice. But remember when I left training and I went to my station to work, one of the first things I did was to ban women being naked in labor. And so it was so strange. Because when you enter a Ghanaian labor ward, the common thing was to remove your whatever you are wearing and put a cloth around you. And it's so easy once the pain comes to put the cloth away so that the woman is left naked. And sometimes you go to second stage and you find the woman naked lying down delivering. I'm like, really? This is really primitive. So once I get that, I say, okay, no, every woman, you come in labor, you have a nightie or a dress that you think you can dispose of, let her wear that. In fact, if I come to review the patient and the patient is not clothed, I just walk away and tell the midwife that, can you please clothe your patient? I'll come back. So over time, they came to accept that first concept. When it comes to privacy and things, you look at the structure of the labor and it's like a dormitory. You enter and you find 5 naked women lying down and shouting and then from first stage, you get to second stage, baby is in perineum, you are moving to another place to deliver, and then they're shouting, "Mama count," and you see the women count like this. And I'm like, really, what is this? There must be a different way of doing this. So what is the solution? All in one delivery bed. You do first stage on it, you do second stage, you do third stage. So once I got the opportunity as a manager to, make the changes, the first thing I did was to restructure the labor ward. So our labor ward had one place like this and then a different place. I mean, you know the place. So the first place where it was used, I just splitted it into 3 cubicles. Every cubicle nicely connected. And then the other side, which was second stage, was another 3 cubicles. So at every point in time, you have 6 cubicles. Then you put in all in one delivery bed. And then you say that the companion, preferably the husband, should be with the woman. If husband is not there, the mother, whoever the woman chooses, as has been said. The advantage is that, you see, when somebody's husband is sitting down with her laboring, how does somebody come and insult her and abuse her verbally and physically? So just the infrastructure alone, some of these things, so top management or leadership is so critical when it comes to these things. So immediately, all those things went away because the person's mother is sitting there. Then you've come and you are shouting on the daughter. It's not possible. They will all face you. Even though the women, some of the men started saying, "Hey, they say the mutumu do you collapse you." Somebody told me last week that when she comes here, we are not careful, then she herself too will be admitted. I said, "No, you try and come." So that is very important, and that also. So again, as part of this, I mean, we were surprised. I mean, as some facility that was good 2018, I entered the top place, I mean, really. And then it was this first stage and second stage. And I said, really? I mean, we were just so disappointed that how could this be done in 2018? It must be cubicles. So if that is done, and well, it doesn't take too much do that, looking at the importance of this. And then, of course, then the training comes in. And when all that is done, in addition to training our midwives to do the essential newborn care, including putting the baby on the mother, doing the attachment at cesarean section. Nothing prevents that, and we are doing it. But all this comes up with training and training. And when you do that, I mean, one lady came to the center to do her PhD, a midwife, I think 2018 thereabout, and she was just shocked. She was like, I mean, this is such a departure from what is in the literature, because she thought she was coming to come and write this kind of thing. And then she came to write the opposite at our center, and she was just thrilled. And I'm sure once we start promoting this, it is just going to take effect. And then we all, as health workers, whether you are working not just in maternity, but everywhere, just learn to talk to patients politely. It doesn't take anything away from you. I mean, my friend came and was telling me he works in the US. So as somebody said, it's not only here. He was saying that, what do doctors get from being proud? We were not taught that in medical school. You see, he kept on emphasizing, and that's where sometimes people say they didn't teach us ethics. No, he kept on saying we were not taught that in medical school. So why do people do that? And that you lose nothing from being humble. So please, let's do these things across wherever we are. Let's learn to talk to your patients nicely and treat patients respectfully, and we'll get there. Thank you.
Okay. So there are a couple of questions from our online audience. Somebody says, I'm a medical student and I observed so many of the things Dr. Bonsafo highlighted going wrong in the labor ward and in even theater. How can we be empowered to help or correct such of those senior staff mistreating patients without without offending them or putting ourselves in trouble? And then somebody else says, global studies show that the high income countries disrespect is more of choices relating to their care abusive care. Respectful maternity care has been added to the midwifery curriculum since 2015. That's also somebody's comment. And another person is saying that, what is the way forward in Ghana concerning the involvement of partners in the old traditional settings of our wards? Dr. Wama,
Dr. Wama has mentioned this.
Yeah, he has mentioned. Another one say, interesting piece of research to make lasting changes in these behaviors will take strengthening the healthcare system via changes in the nursing and midwifery and medical school curricula. Setting for short-term training here and there is only temporal support, and the impact of that would not be a lasting one. Then another person says the architecture of labor rooms also needs restructuring. If more than one woman or are in the labor room at the same time, it may be difficult for companions to be allowed in. And then another person says, thank you, Dr. Bonsafo. Do you think that lack of education in general on childbirth is part of the problem? I find that in Europe, women are more educated on pregnancy and labor, and therefore are more empowered. Yeah. Another person says that going forward, I think that midwives should be in the planning process when things are being done. Our labor wards are not well constructed. And the last but one says that, what was the nature of the verbal abuse women were subjected to? Were there grading of the severity of verbal abuses? And final one says, did your study find correlation between mistreatment and perinatal mental disorder?
Right. So thank you very much. These are interesting comments. One person mentioned what we can do. Women are, as I said, I think the power, we haven't empowered them well. We need to probably empower women. They have to know their rights. They have to know that it's their right to ask for this. It's not like it's a favor. They always say, oh, you are the doctor, just do whatever you do. You push them, they don't talk. They in some way. So we need to start the education, let them know that it's wrong to do that, because as Dr. Bia said, we think once we have achieved a live birth and baby not dying, it's good. But it's good, but the experience, because of that experience, and some of them can actually use forceps to hold them. I don't know if, Dr. Wama, you heard about it. When you are not pushing, they can use, instead of pinching you, they use the instrument they use to pinch you. And that can be very bad. So we need to educate ourselves and empower women. And Dr. Wama, do you want to add more to it?
I just remembered, you see, instead of doing push, that traditionally people think that is what makes them push, it doesn't. It just creates a whole lot of anxiety on the labor ward. And oftentimes, exactly, a lot of confusion. Oftentimes, you even notice that the woman may actually not be in the real expulsive phase of the second phase. Because when the woman dilates fully, the baby has to descend first. So that's the descent time. But sometimes they just position the woman during that descent time and make chim. So obviously the woman would push and be tired. And it's also because you, the caregiver, your knowledge about the delivery is poor. And that's why you are asking the woman whose baby has not descended to start pushing. But if you waited for some time, the baby would descend nicely into the perineum. Then it is at that stage. And at that stage, all you have to do is to be encouraging. You are doing well. You're doing well. Continue. You are doing well. Oh, this is lovely. The person's husband is there giving support. You see, and once you do this, you see it nicely. Baby comes. And I'm telling you, I've experienced it so many times. When I've entered, when people are doing all this, I said, stop. You coach them to do what I just demonstrated, and then baby comes and they'll be looking at you. And you say that I'm power. So there are no difficult patients. No, that's why we are professionals. We have to show our professionalism when things are not going on the way we expect. So that's what I would say.
All right, thank you, And also, you know, in the developed world, when I went to Michigan, they are in labor. You have your room. They are not. We don't give them a lot of or adequate analgesia. They are in pain and shouting. Over there, you know, they give epidural like it's a routine. So the woman can be in labor and just there, no major pain to cause trouble. You know, for you to also cause trouble to her. And so, so those are some of the things. But maybe with time we give injections as well, but you have to be very careful with some of those things. And so, are we done with the questions?
Is there any other question from here? No. Yeah, we are done.
All right. So I think most of the rest were comments. So
yes, they were comments.
Thank you very much.
Please, let's do it for him. I hope we have all learned. I have learned. And now you see that from what Dr. Bonsafu is saying, ADET is very important. You see, it's very important. Isn't it? Yes, so please, let's use ADET. Is there anyone here who doesn't know what ADET is about? Is there anyone here who doesn't know ADET? We all know about ADET. We all know about ADET. Okay, so please, let's go and continue using ADET. I'll call on Dr. Ekufu to give the closing remark, the head of the Research Training Department.
Thank you very much, our Deputy Director. I want to thank Dr. Bonsafu for this very informative presentation. It's been very interactive. We exceeded our Zoom capacity. YouTube came and was almost getting full. So thank you very much. Take-home message, Dr. Boama has done most of it for me. But to add that mistreatment is pervasive in West Africa. Younger, less educated women at higher risk of going through mistreatment, and there's a need to address inequalities. At UGMC, our goal is to raise the bar and be the preferred place for healthcare. And therefore, this study and presentation is to stimulate us to find ways to ensure that when people want to choose a place, they don't have to think twice before coming here. Maintain the standards. They should come. Yes, they should come. What I also noticed was that 15 minutes before delivery, most of the mistreatment were recorded, and 15 minutes after. Not sure what happens in those 15 minutes. Generally, in the 1 hour prior to delivery also, a lot of these were recorded. And so as we work with the patients, let's take note of this time in particular. After you have given your best for 9 months, those 15 minutes shouldn't spoil our record. Also striking was mistreatment of babies, including slapping and the separation of them. I think it would be good for UGMC to do a study on measuring labor experience at our facility, because we know we are doing well. If we do a study and we measure it, we also publish and put a very good spot there, so that it's not only about the mistreatment, but the positive as well can come out. Let's ensure better communication with ADET. And my final take home was caring for the carers. We appreciate the work that we are all doing in caring for the patients. And Dr. Boama is here. We'll continue to put in measures to ensure that the carers are also well cared for. Thank you very much for coming again.
Okay, so thank you all. We would like to give a special thanks to Dr. Kwame Edubonsafu, my personal person. So we thank you very much for taking time out of your busy schedule to come and share this knowledge with us. We are so grateful. We'd like to thank Dr. Boama, Director of Medical Affairs, for leaving your big office to be here with us this afternoon. We are grateful. And then we'd like to thank all heads of department here for coming to share with us, all staff. Also, we thank you. All visitors who are visiting UGMC for the first time because of Dr. Bonsafu, you are welcome. And we hope that you come to visit again. And we'd like to acknowledge our online we were oversubscribed. The Zoom was over 100. YouTube was also oversubscribed. So this is how important that I told you that I was happy about this topic. So I think at another date, we'll call you again to come and share with us, because it looks like more people wanted to be part, but they couldn't have the opportunity. So another date, we'll call you again. Thank you all very much for coming. On this note, I'll call on Mr. Carl to give us the closing prayer so that we can depart. Thank you.
Please shall we pray. Father in heaven, we thank you for such a beautiful discussion. We thank you for the ideas shared and the knowledge gained. We pray that as we depart, may your grace go ahead of us and sustain us in all that we do. So all these ideas may grant us the strength to be able to carry out our work in improving upon the life and health of our patients. In Jesus' name we pray. Amen.